A bleak picture of mental health care in the UK. A new report reveals how years of underinvestment has left the most vulnerable without the help they need. Why is mental health care being neglected? And how is it being treated elsewhere in the world? This is Inside Story. Hello and welcome to the programme. I'm Hanna. Mental health care is so poor in England that people's lives are being ruined. That's a message from a review set up by the National Health Service. The report reveals how mentally ill people have failed to get the right help at the time they need it. Mental health problems include things lots of us suffer with, like anxiety, depression and eating disorders. And health workers are saying the failure to properly treat them is having a human and financial cost. So what are the findings in this report? Well, it found that 1 in 4 people experience mental health problems every year, but 3/4 of people who need treatment aren't receiving any help. The report also found suicide rates are soaring. It's now the leading cause of death for men aged between 15 and 50 in England. The average waiting time for sick children needing help has gone up by 50% on the year before. And despite the known impact of untreated postnatal health problems, less than 15% of areas provide effective services for women. The British government says it will inject more than $1 billion annually to reach 1 million people in need by 2020. Well, let's get straight into our conversation and introduce our 3 guests. Joining me in London, Jacqui Dyer, Vice Chair of the Mental Health Taskforce and co-author of the report. In Cape Town, Crick, Lund, CEO of Prime, the programme for improving mental health care. And in Accra, Yaro, Executive Director of Basic Needs, Ghana. Welcome to you all. Let's begin with Jacqui Dyer. The report and what has been a positive government reaction to it is described as possibly a landmark moment, which could lead to the biggest transformation of NHS mental health in a generation. Is that overstating it, do you believe?
I think that it's a really positive report that is in some sense a landmark, and I think that the approach that was taken to actually create the report is what makes it have the potential to be something that could transform mental health services in England. The task was to develop a cross-system report of all ages for 5 years. So it's the part of a series of reports that have been commissioned by NHS England. It's an independent task force, and it's part of the 5-year forward view of the NHS. And our task was to shape the priorities for the NHS. And in doing that, we had contributions from over 20,000 people across England that contributed to our survey and other mechanisms to feed into the report, which enabled us to develop particular themes that we could rotate and develop the recommendations with the NHS arm's length bodies to attend to this absolute crisis in mental health, with a focus on then priorities around improving access, improving prevention, improving the quality of care, and improving better integration between physical health and mental health. Of particular importance, I think, is my involvement as both a service user, a carer, a black woman, a professional, as a lived experience expert, as one of the main contributions within the body of advisors and experts that work together as the task force to create this report.
Let me just put a point to you there, Jacqui. In the past, less than a tenth of the NHS budget has been allocated to mental health services. Why this disparity between mental and physical treatment? This report clearly aimed at narrowing the gap, is it not?
the aim is clearly at narrowing the gap, and I believe in the Health and Social Care Act, there's the intention around to ensure parity of esteem between mental health and physical health. So the report attends to that, but this is a very long journey. The way that mental health services have been neglected so badly in the past has meant that this gap has continued to be, and this calls it sharply into the foreground of attention, that we cannot continue to ignore mental health as a component of physical health and physical health as a component of mental health. And so the resourcing is something that NHS England has made a priority, as has the government. It's down to all stakeholders in the system, actually, to now make this happen, because people can be quite easy to stay with old patterns of behaviour. But in terms of making, one of the things about the report is that it makes data much more transparent, and how we are spending money across the system, i.e. in terms of what we spend on mental health and what we spend on physical health.
Let me go to Peter Yaro, if I may, Jacqui. This report obviously highlights mental health treatment shortcomings in a developed country, but 450 million people are infected by mental illness worldwide. And in developing countries, close to 90% of people go untreated, according to statistics. Peter Yaro, these are clearly appalling statistics showing how internationally mental health treatment is lagging behind, not just in the United Kingdom.
Yes, thank you very much. You are very right. And hi to fellow panelists, Dyer and Crick. You are very right. And I just contextualize that in Ghana, where less than 10% of people who require services actually get it. And even of those 10%, what they receive are what you would find in institutions, psychiatric hospitals. It is good that over the last few years, community mental health have evolved and evolved well, but there's still a large number of people who require treatment services that hardly get them. And it is just the epitome of all those 450 million people across the world, particularly in low and middle income countries or least developed countries that require them. So I think in response to some of the questions that Dyer was answering to, what our work practically on the ground have come to prove why there is lack of attention to mental health is that there are investments in physical attempts to treat physical conditions which are actually mental in nature that should have had psychosocial support. So there is this emphasis on providing treatment that people think are physical in nature, even though they have physical connotations, which actually should have been effectively addressed with psychosocial support, with mental health care treatment services, than giving the needed attention or trying to make it a physical condition. So you will see that there will be overwhelming emphasis on providing investments to treating physical conditions, when similar investments should have been made for mental or psychosocial disabilities.
Crick, Lund, early on in this discussion, we've heard repeatedly the issue of narrowing the gap between mental and physical health care and how the two are absolutely intertwined. Do you agree with this point?
Yes, completely. And I think it's unfortunate that for a long time, international development assistance in the form of funding, for example, for the Global Health Fund, has tended to focus on infectious diseases. And of course, while these are critical conditions like malaria and HIV, TB, and so on, there is a very important mental health component to those. So we know that a much larger proportion of people living with HIV are depressed than in the normal population. And of course, we also know that depression affects adherence to antiretroviral medication. So if you are depressed, you're much less likely to take your antiretroviral medication. We also know from studies now that simply treating depression alone not only improves adherence to medication, such as HIV medication, but also improves HIV outcomes. So we really need a more holistic approach to healthcare in both developing and developed countries, which includes mental health and provides the resources and skills for primary healthcare providers to detect and manage common mental health problems in a way that's integrated fully into the healthcare system.
Well, Jacqui Dyer, there you hear the expression holistic approach to the matter. Would you agree with that?
That's exactly the kind of thinking that's being encouraged by the Taskforce recommendations. It's this sense of integrating the body and the mind, and there's no way, as has been said, that you can possibly get really good outcomes for physical health issues without attending to the mental health issues. And so I really share the views that have been shared just now. It's absolutely vital to look at it in a holistic sense and actually to think about this right across the system. So some of our recommendations are not just for the health service, but actually for wider areas of government, such as local government, the DWP, employment, and so forth. It's about thinking in a really holistic way, because all of these features interact to affect somebody's mental health status.
Well, Crick, one of the many recommendations in the report that Jacqui Dyer co-authored is, for example, a recommendation to improve community mental health services, to cut down for people on travel time, to cut down on the demand for in-hospital patient services. Now, this is a template, in a way, a suggestion that would apply to any society across the world, would it not, to improve community mental health values?
Yes, that's absolutely correct. So we know that in high-income countries, many countries have had a long history of institutional care. And since the 1950s, in many high-income countries, those large psychiatric institutions have been downscaled and reduced. In many low and middle-income countries, those resources have not really existed in the first place, and there's an urgent need to develop community-based mental health care. So we're working very closely with the World Health Organization in our PRIME project, the PRIME project being the Program for Improving Mental Health Care, to set up district demonstration sites. And we're working in Ethiopia, India, Nepal, South Africa, and Uganda. And in each country, we have a district where we're working with the district health management team to implement the WHO MH-GAP intervention guide and evaluate the impact on improving access to care, on improving the detection of common mental health problems like depression and alcohol use disorder, and assessing the impact on the economic circumstances of people who receive care for conditions like psychosis, epilepsy, depression, and alcohol use disorders.
Well, Peter,
sorry, you go ahead.
So I was just going to go to Peter Yaro on the same matter. I mean, the issue of community mental health care, another advantage of it as well could be that societies are taking their treatment into their own hands to an extent. It gives them control over their own welfare and over their own destinies. Would you agree with that?
Absolutely. And just continuing from Crick, that is doing a bit more for people to understand their conditions and move away from putting it as being the cause of witchcraft or a spell that has been cast on you, to saying that this condition I experience is one that is manageable. It is not because of witchcraft, it's not because of a spell or a curse, but it's just as any condition or ill health anyone can suffer. And for that reason, I can live positively and feel happy and proud for what I am and maximize my own potentials, even though I have this condition. And that is why the idea of working with service users and caregivers has been very pronounced in the work we do in basic need, making service users, families, and primary caregivers being part and parcel of the care process, and seeing to it that the person is not moved out of the community to a facility, an institution somewhere, and when somebody says that I think you are well, come back to your family. There are doubts, but As you stay within the community and go through treatment, everybody in the family, in the neighborhood sees your progress, and your integration is easier. You can take better control of your life. And that is how community mental health has really made it quite empowering. Apart from maximizing general healthcare service facilities in a holistic way that you don't have to set up another set of infrastructure to deal with mental health, but working within those general healthcare facilities enhances the way we could make use of personnel. As Crick has mentioned, the district teams, they share tasks, they are able to support each other. The vehicle that is used for immunization can be used by the community mental health officer to talk about depression in pregnant mothers and newly born, pregnant women and newly born mothers. And that goes a long way to see the number of people who take up immunizations, who go for ANC services, and who ensure that they get skilled deliveries and improve maternal and child health care services.
Well, Jacqui, Dyer, if I may just, I just wanted to highlight something that came up in the report, Jacqui, Dyer, and that was the astonishing figure that suicide is a leading cause of death among men between 15 and 49, and also that suicide rates within England, at least, have been soaring in recent years. Clearly there's a socio-economic base to this. There must be other factors that lead to such a massive increase in suicide rates, for example.
I think that's the point that I was saying earlier, is that we have to be more sophisticated about how we think about mental health, and it's not just within health services. Other aspects of our society have a role to play. So employers, education, schools, universities, local communities, all have a role to play in this. And in fact, what we need to be is much more psychologically minded as a society, wherever you are within that society. So the part of the task force which is about improving prevention strategies is absolutely critical. And this is about community education. This is about empowering communities to recognize the signs and symptoms of their mental health, of their well-being, so that they can actually manage their difficulties or access treatment much, much earlier than what some of them currently do, or have a place where they can ask for help much more earlier than what they actually do. And in certain communities, particularly for black and minority ethnic communities, their access to help, and including actually lesbian and gay communities, their access to help is often at the most latest stages. We need to be moving much more upstream, and so the prevention agenda is really critical, so that people don't end up in the most acute setting, and their recovery is that much harder than what it would be if there was earlier intervention. So it's a whole mindset, a whole new way of thinking that we need to think when we think about physical health so easily and without any problem as a society. Actually, we need to be thinking about mental health in the same way. It cannot be as taboo or stigmatized as what we've had it be over generations. And that thinking must permeate not just the institutions, it also is about actually the general population. Families, schools, communities need to be much more comfortable about talking about a component of their selves, which is a natural component of their selves. It's not something on the other side of the street. It's something that's an integral part of who we are as human beings.
Well, Crick, Lund, that clearly is a critical factor as well, not just within the United Kingdom, the reordering of the mind, the reordering of the way in which mental treatment is seen, is it not?
Absolutely right. And I'm really glad you picked up on the issue of poverty and inequality, which is a major driver of mental health problems at a broader social level. We've conducted systematic reviews of the relationship between common mental disorders and poverty in low and middle income countries, and found consistently across a diverse range of countries, diverse range of studies, that poverty and various poverty indicators are strongly associated with increased risk for common mental health problems like depression and anxiety disorders. And so we think it's really important to include mental health in broader international development policy. And it's very encouraging that with the release of the Sustainable Development Goals in 2015, mental health is now included. We feel that it needs to be much more foregrounded. It needs to be more clear measures and indicators of how progress on mental health targets are to be measured in the years to come. But we think it's really essential to integrate poverty alleviation interventions with mental health interventions. And incidentally, it's great to have Peter Yaro from Ghana Basic Needs on this panel, because Basic Needs in a number of different low-income countries has really been doing pioneering work in integrating livelihoods and poverty alleviation strategies with community-based mental health care. And I think that's a great example of the way to move forward.
Well, Peter Yaro, I mean, we're hearing all the time about holistic approach, and here we are hearing about the direct correlation between poverty and mental health. So clearly there are so many factors involved. It is not limited to paying money, to increasing budgets. It's also linked to improving the living standards of people, is it not?
Absolutely, and Crick has rightly put it. And that is, again, why our work is linked with ensuring that there is improvement in economic well-being, starting from maximizing the potential of the individual to know that the illness, much as it may be disabling, does not make you completely a useless person, and that you still have something to offer to your family, to your neighbors, and to yourself as being a productive economic contributor to well-being and welfare of the families and the individual. And again, just to echo that this report is really very timely. UK, England, as a global leader, would really contribute to ensuring that the Sustainable Development Goals that now include mental health is given the needed muscle and leverage to let this work. So focusing mental health care services in economically disadvantaged communities, even though in Ghana we may not say we have Black, Asian, and minority, we have quite a good number of people that are poor, whose mental health care conditions could have been better solved. They become chronic because people have had no incomes to seek treatment immediately, or the little income or resources they have had to go through various pathways to seeking care, starting with spiritualists, herbalists, and now going around, and after they've dissipated everything, come to the hospital, and that have very dire consequences.
Well, I just want to go to Crick Lund quickly, because we are running out of time here. And what has struck me is the fact that a report drawn up specifically within a particular geographical area, that is England, clearly through this discussion has ramifications and has potential templates for mental health care globally, is it?
Yes, that's absolutely right. And it's very timely for a number of reasons. One of the reasons is that the World Bank and the World Health Organization are holding a major meeting in April in Washington, D.C. on mental health in low and middle income countries. The meeting is called Out of the Shadows. And it really signals a commitment from the World Bank and the World Health Organization to give more policy attention to mental health. And I think the tide is really turning. We've seen in the last 5 or 10 years a whole wave of new research funding in low and middle income countries on mental health and on developing new models for integrating mental health into primary health care, for developing community-based approaches, for integrating mental health with poverty alleviation strategies. But really now we need a big policy push from the international development agencies like the World Bank and from ministries of health in low and middle income countries, as well as, of course, high income countries, to give adequate priority to mental health. So this report from the UK is very timely in terms of a global push, a global initiative for mental health.
Well, at that point, my thanks to our guests, and especially to Jacqui Dyer for being a co-author of a report that clearly does have an important global impact. So thanks to our guests, Jacqui Dyer, Crick Lund, and Peter Yaro. And thank you for watching. You can see the program again anytime by visiting our website, aljazeera.com. And for a wider discussion, go to our Facebook page, facebook.com/AJ Inside Story. You can also join the conversation on Twitter. Our handle is @AJ Inside Story. From me, Mike Hanna, and the whole team here, goodbye for now.